Hello and welcome to this module on vulnerable populations. My name is Mathavi Senguttuvan and I'm a researcher at the NUS Center for Biomedical Ethics. In this third video on vulnerable populations, we're going to look at some cases, scenarios, and potential strategies. Now, this is not to say that this module focuses on any particular approach, but it's to help you identify the best way to care for your patients who may be vulnerable to certain kinds of wrongs. So broadly speaking, nearly every single aspect of providing healthcare and interacting with patients denotes some amount or element of vulnerability. Patients are considered inherently vulnerable due to their physical or mental ailment, and that's why they come to doctors to receive care. Some patients ought to be considered more vulnerable because of an increased likelihood of being wrong. Situational vulnerabilities, however, are much harder to detect, and they're often mischaracterized or misunderstood, and often vulnerable persons have to face some adverse implications as a result. Now, keeping this broad approach in mind, how should healthcare professionals approach and respond to particular vulnerabilities and address vulnerable populations' needs? So let's look at some cases. Maybe this might help you better understand. Consider Madam Noor's case. She's a 78-year-old Malay woman who weighs 98 kilograms, and she has a long history of arthritis. She presents with severe back pain and knee pain, and she has limited mobility because she's only able to walk with significant pain. She is also a fall risk. She's accompanied by her husband and her son. She's primary school educated, but she can speak some limited English. Based on a thorough evaluation of her case, the options presented to her are either total knee replacement surgery, which has increased risk of complications due to her age, or a dedicated weight loss program combined with exercise and physical therapy. So when you look at this case, you might think of some questions. Is Madam Noor, in this case, actually vulnerable? In an inherent or ontological sense, yes, of course. She is old. She has a medical condition, so she needs care. But are there any situational or conditional vulnerabilities that you can identify, and to what? And if you do characterize her as vulnerable, what use is that to facilitate the best care for her? While providing care for inherently vulnerable older adults, oftentimes healthcare professionals end up having a checklist which involves assumptions behind deducing these situational vulnerabilities. For example, in Madam Noor's case, her age, aside from her age, her educational limitations, racial background, and other potential aspects that we haven't actually raised in the case facts may influence the professional's perceptions around her capacity to make informed decisions. They may in turn take some paternalistic approaches that may be biased or potentially stigmatize her, and the care plan might be adversely affected as well because of presuming some situational vulnerabilities that may not exist. For example, because Madam Noor has limited educational background, it may be presumed that she doesn't actually understand what the treatment will do for her or how important it is for her, or there might be attempts to minimize her opinions because she may not understand what the treatment actually means for her. Now, Madam Noor has been struggling with her condition for several years, and she is the authority on her experience. And she knows exactly what she's been through all these years. So these sorts of presumptions can have a negative effect on how she decides on her care plan, and which may lead to her relegating the duty of deciding for her to her family, resulting in undue influence, etc. Now consider Finn's case. Finn is a 16-year-old adolescent who is currently a senior in high school. Finn's main complaint is frequent and chronic abdominal pain combined with diarrhea. Finn additionally presents with some psychological distress and anxiety over applying for university admissions. There's no apparent cause or indication from any relevant laboratory tests and radiological scans. So the doctor, with no other investigation to do, provides a preliminary diagnosis of irritable bowel syndrome. The options provided to Finn are to control the symptoms with medication and exercise, relaxation, and stress-relieving techniques. In this case, can we consider Finn vulnerable? He is a minor, he is an adolescent, which comes with a different set of problems and issues altogether. But yes, in an inherent ontological sense, you can consider Finn absolutely vulnerable. But when it comes to the situational or conditional vulnerabilities, how exactly do you understand it? And how does that help you build an appropriate response to this case? Are you making any presumptions, or are you leaving out certain factors that may influence how the care plan is conducted? Before we get to a better look at Finn's case, also look at Drew's case. Drew is a 35-year-old man who walks into a GP clinic. There are no major complaints or presentations besides darkening bruises on multiple points of the body and more severe localized pain at the sites of the bruise. Now, seemingly due to sports. He's unaccompanied by any relatives, but indicates that he is married. When pressed about the details of the injury, he does not wish to discuss them, and he's very anxious to go home as soon as possible. So the options put forth by the healthcare professional are to prescribe painkillers and send him on his way, or to investigate the sources of the pain or bruises further. This question, can we actually consider Drew vulnerable? Again, in an ontological or inherent sense, maybe because he is a patient who has come requesting care. But situationally, this case is slightly different because this person seems like the ideal, strong, and non-deviant form of a patient who is not exactly vulnerable. So oftentimes, the healthcare professionals might just provide the painkillers he requests and send him home. But what exactly is suspicious about the case that might warrant an even better response? There are some commonalities between Drew's case and Finn's case. We see that there are signs to hidden vulnerabilities that are yet to be uncovered. For example, in Finn's case, physical presentations could be due to a variety of psychological and emotional factors, or due to an underlying physical conditions that is difficult to diagnose, for instance, fibromyalgia. Now, Drew could have been subjected to physical or emotional violence by his spouse, as a result of which he has obtained these bruises. But this is not often investigated because there are particular conditions that are placed on what the ideal patient should be. Healthcare professionals are then placed in an unenviable position of having to dig through several barriers to identify these vulnerabilities, failing which a misdiagnosis or failure to provide adequate care can exacerbate the problem. Finally, consider Lily's case. Lily is a 44-year-old woman who visits a doctor seeking breast cancer screening. Preliminary investigations through a mammogram reflects positive results, and she is immediately advised to have a mastectomy. Now, following the procedure, Lily acquires an infection, resulting in significant delays in aftercare. A thorough investigation reveals no malignancies, resulting in further psychological distress and depression. So in this case, is Lily vulnerable? From the inherent sense, yes. From a situational sense, we can see or go back to our discussion on pathological vulnerabilities, because the appropriate response that one normally has to preventative care has actually ended up causing further or additional vulnerabilities. Statistics indicate that significant numbers of breast cancer overdiagnosis in women. Women are subjected to fear-mongering, increasing pressure to get screened, and they are nudged into invasive and often unnecessary procedures. Misdiagnosis or overdiagnosis results in the creation, as we just discussed, of new or exacerbation of existing vulnerabilities. And this is what we call pathogenic vulnerability. Now, this new or novel form of vulnerability demands that we have a better model of care, which actually addresses women's inherent vulnerabilities, avoids stigmatization, as well as paternalistic responses. Based on a quick comparison of all the 4 cases we've just looked at, we see that Madame Noor's case looked at labeling her as vulnerable because she is elderly and may not have capacity to decide for herself, even if she does, and assuming certain forms of vulnerability when they may not exist, and then approaching vulnerability as a static concept. Similarly, in Finn and Drew's case, which have more commonalities than others, there is a hyper-focus on biomedical indicators and a failure to recognize hidden vulnerabilities that is rampant. And finally, in Lily's case, there is overdiagnosis and prejudicial outcomes, and there is an unintended generation of pathogenic forms of vulnerability. What was common to all 4 of these cases was approaching vulnerability as a static concept rather than the dynamic concept or adapting concept that it is. Some have referred to vulnerability as a chameleon concept, which changes its meaning depending on the context in which it is applied and by whom it is applied, for whom it is applied. Based on this entire module so far, we do have some quick takeaways. Vulnerability is a contested concept. There are no universally accepted definitions or approaches. Some of them have been considered too broad, and some have been considered too narrow. We saw that legal or practical attempts to diagnose and respond to vulnerabilities are more often than not in tension with these conceptual uncertainties and abstraction. In the clinical setting, the objective behind identifying specific vulnerable persons is still largely with the aim of protecting them from harms, exploitation, etc., more so than other equally important objectives. Oversimplification of the concept has resulted in adverse and negative connotations due to the increased risk of stigmatization and stereotyping. Calls have increased for shifting away from this concept to more practically useful markers, such as at-risk or marginalized groups. However, rejecting the concept outright is equally unhelpful because vulnerability provides a helpful starting point in recognizing and acknowledging people who may require more care or attention than others. While the aim of this video was not to zero down on any particular approach as the right or ethically suitable approach or account, we do have some suggestions on ethically appropriate responses to vulnerability and vulnerable populations' needs, regardless of the approach that you take. For starters, increased attention must be paid to aspects of care beyond biomedical markers or physiological aspects, including social, political, and other welfare-related contexts. Attitudinal shift is required toward patient-centric approaches and away from the goal of protection or paternalistic responses. Now, advancing the goals of care beyond protection could include empowering self-management of risk, enhancing capabilities in taking care of themselves, reduction of risk factors, etc. On a more social justice perspective, looking inwards at institutional policies and protocols to engage with justice-related structural factors that may render certain groups vulnerable is also important. So speaking to your hospital management or chairmen of medical boards, etc., is important to ensure that these sort of structural factors are also adequately responded to by your institution. We hope that this module has been helpful in enhancing your knowledge and understanding of vulnerability as a concept, laws and ethical policies and guidelines surrounding vulnerability, as well as a case-based understanding of vulnerability and how to respond to vulnerable populations' needs. Thank you.